Good morning. Today, actually, we're just going to talk about the hypervolemia, particularly in the ICU setting. And feel free, if you have any questions, just interrupt me. So if you look at it, we're going to talk about the hypervolemia, particularly in the cardiovascular surgery patient, in patient who has the cardiorenal syndromes. Is a good. We're going to talk about this Aquadex, so it's a new device as therapy for ultrafiltration. We're going to see what's the clinical evidence for it. And then we're going to have some product overview, and at the end is QA. If you look at the volume overload on the surgical patient, fluid overload has a strong correlation with the length of the stay in the ICU. It's a nice paper, as you see it, is published by Stein. You're looking at it, just look at the hypervolemic patient, and then those who has a hypervolemia and have a acute kidney disease. Definition of the acute kidney disease is rising of the creatinine more than 0.6 on this particular study. Then we want to look at the survivor and the non-survivor. If you see the black, you see a series of the black square and black circle. Black circle is this non-survival, just who had a hypervolemia. And then black square is a non-survival who has a hypervolemia and the AKI. And the white circle and the square is the same thing. Those who has a hypervolemia, they survive. And then the square is those who has a hypervolemia who survive and they have an AKI. So if you look at this, the nicely designed studies, the progressive fluid overload after the cardiac surgery may be an earlier and the more sensitive marker of the renal dysfunction, that's serum creatinine. So as an entity, as a hypervolemia can determine which patient is going to develop as far as the survival. What else we know in the cardiac surgery patient? Moreover, this part D, he published the paper, I think if I remember, 2008. Not only this hypervolemia is going to show us the length of the stay in the ICU, by itself as an entity is as an indicator of the survival. If you look at it on the y-axis is the predict probability of the mortality, and then it's going to be an intravenous venous volume per liters that the patient has it. If you see it, those just as an entity of the hypervolemic patient in cardiac surgery, it has an effect as far as the survival. What else we know? This study was published in Canada. It's a multi-center study. They're looking at it. So not only the hypervolemia is going to show us length of stay in the ICU, it's going to show us those who are going to have a higher mortality. If you see the third most common cause of the readmission, the first 30 days. And then when you expand the idea between the 30 to 90 days, that's the first cause of the readmission. So on the right slide, as you say, the first line is going to be a rate of the readmission. So in cardiac surgery, because we give a massive amount of the volume, we had the early experience that the hypervolemia as itself is an entity, not only increase the length of a stay in the ICU, is going to increase the mortality, and then we have a good valid evidence that when you look at the, as far as the quality metrics, is one of the important cause of the readmission. So let's see what we know about the hypervolemia, particularly last 10 years or so. We try to emphasize about the pathogenesis of this kidney failure. This is the slide is going to be. So let me conclude this one before I get to that one. So in cardiac surgery patient, it's hypervolemia. Those are the facts. And the changing of the serum creatinine has shown a significant and independent associated with the combined event of death, infection, bleeding, arrhythmia, pulmonary edema. And then we know that the early identification of the fluid overload is essential to establish adequate management in cardiac patient. So shifted over on the last 10 years, which we know about the pathogenesis of the AKI in the cardiorenal patient. That's a nice study. If you're looking at it, venous congestion, which is defined by the CVP, is the most important hemodynamic factor during worsening renal function. So it's important to know it. If you look at the area under the curve, that if you see for the sensitivity of it, the creatinine by itself is the red line, and the green line is a cardiac index. So if the impression is on the cardiorenal patient, lowering of the cardiac output can cause worsening of the renal failure. This study actually nicely has been shown. Venous congestion by itself, which might be related to the hypervolemia in more than 90% of the time, is a much more sensitive index. And we know that, particularly in cardiorenal patient. What else we know? We know it if you see it now, we've got a broad spectrum, and then look at those who have a cardiovascular disease. If you look at it, increased central venous pressure is associated with impaired renal function and all-cause mortality. The same concept which I told you about the cardiac surgery, which we picked it up a long time ago because we see the massive group of the patient with the short period of the time, they get huge amount of the volume, has been proven in the cardiorenal, and this expanding it almost all category of the cardiovascular disease. Moreover, is this study actually, if you're looking at it, they look at the intra-abdominal pressure, those who has a heart failure. If we be able to bring the intra-abdominal pressure by either diurese the patient or give a vasodilator, the chance of the recovering of the kidney function is going to get improved. What you see on the left side is slided, the more you have a venous congestion, the more amounts of the kidney function deterioration. However, when we start to the diurese the patient, or in this particular study, or give a vasodilator, the renal function has been improved. So it's cause actually I try to generate this slide. From a long time ago, at least series of colleagues of us, we thinking it, is it this, we know it when you have an acute kidney injury, with the new definition, may cause to go to become hypervolemic. But the whole idea is, does the hypervolemia by itself can cause to get more acute kidney injury? And then we have a good data is out nowadays by the monitoring of the CVP, and probably you have seen it almost every year is some publication. So instead to look at the kidney function as a general, to see is the forward flow, because I calling it, unfortunately, is this concept we had as a physician, we call it plumbing. We thought the flow is going to get down to the kidney and the kidney is going to be failed, which actually this hypothesis is refuted strongly. So what do we know? Not only the forward pressure is important, backward pressure as far as the function of the kidney is very important. And one of the most common cause, those who have a heart disease, if you look at it, this cause is the hypervolemia. All right, traditionally, if you see, if the patient is hypervolemic, what we do? So that we had a tool is the Lasix or diuretics, as generally speaking, potent loop of Henle diuretics. But if you see, by the time we figured out, the series of the question has been unanswered. For example, we know 40% of the heart failure patient have a poor diuretic response, which is a huge group of the population. We knew that. Why we knew that in cardiac surgery patient? Because when the patient goes on the heart-lung machine, we induce cardiogenic shock on them. And when they come out of the operating room, we give them tons of the volume. We didn't see adequate response with the diuretics. Second thing is a lots of the question between the clinician is there that how do we define diuretic failure? So it's not the unified approach. Most of the time, we started a little bit low dose, then we increase the dosage. If it doesn't respond, sometimes we started drip. Then we have an additive, and it sees a series of the papers out in the wide spectrum from Doesn't make any difference between you give an infusion or used to be, when I was a fellow, used to be in Bible that everybody is going to come, you're going to give a Lasix infusion because you get a better diuretic response. But the question that everybody knows, do we have a maximum dose of the diuretics? We are not sure. Second one, do we measure amount of the total fluid removal? What's the adequate? If the patient already get 150 cc per hour, what meaning of the urine output is going to be that particular patient is on multiple pressors and the volume removal is going to mean for them? Do we measure 24 hours urine output? If you look at the hypervolemia, and the idea is you catch it at the end of the 24 hours, we lost a good amount of the time to get the desirable effect. And then the last one is, do we measure frequency of the administration and the response to the previous treatment? Most of the time, if you see as an experience, we started with, we have it nowadays in the heart failure, several studies has been shown, doubling the dosage of the Lasix probably is the better response, but it's not a unified approach. You give it double the dose of the Lasix, for how long you're going to monitor how much urine output. So, and usually we're going to lose this time-lead bias that we have. Another concept actually has been evolving is going to be potential causes for that diuretic as a main tool that we have it, why we have this failure. Does this a non-compliance, particularly on the setting of the patient as an outpatient, is a huge issue? Is it drug not reaching the kidney is going to be a non-adherence? What's the percentage of the Lasix is going to be bonded with the albumin? Nutritional status of the patient? Is it dose or the frequency is going to be a compliance of the patient? How many tablets of the Lasix, for example, can take it? And then is the poor absorption of this, as I told you, on this. Usually, if you see a congestive heart failure patient, if they go on the long term, they don't have a great absorption because of the mucosal edema. Is another concept is important, particularly from the Mayo group, that they come with this whole Lasix stress test. So as you may know, this Lasix is going to go and secrete it to the proximal tubules. So if the idea is most of the pathology of the AKI nowadays through the single nephron theory and those things we're working on it is on the proximal tubule, and the Lasix is going to be secreted, we have already the pathology, our medication does not get there. So if you see the whole promise of the Lasix challenge test, you give a healthy dose of the Lasix, by their definition is around 140, and then what you can see it, you can look at it within the response of the kidney for the urine output, and you can determine the outcome of the AKI. But this practice, I'm pretty sure all of you have seen it, when you give a good dose of the Lasix, not necessarily you're going to get a desirable effect. Other things that is important is decreased kidney blood flow, decreased functional kidney mass. All of those is going to happen. Insufficiency of the kidney response to the drug because the low GFR. And another concept is important is the heart patient. When you say by definition, if you see it on congestive heart failure, means intravascular volume is down, but total body, we call it effective intravascular volume is low, but the total body water is high. So it means if the Lasix is going to look at the blood flow and the intravascular volume, how are we going to address the extravascular volume, which is most of the problem. So now we have it. Personally, I have experience a little bit more than 10 years that you're mentioning it with the Aquadex, but we use it routinely last 10 years. So what is the Aquadex flow? Is a form of the ultrafiltration, is a simplified form of the ultrafiltration. What it means, it removes all isotonic plasma water. So it means it removes mostly of the water and some of the electrolyte. So that's one. The second is a safe to achieve the safe mode to achieve the euvolemia, precise control and rate and amount of the fluid removal. What it means? It means the patient come after we use this one is not to see what's the response of the patient like with the diuretics. This one very easily, I'm going to show it. You can dial the amount of the free water that you wanted to remove on the patient on the time base. Let's say you want to remove a 200 per hour. Within 5 hours, you're going to be a 1 liter total fluid removal. So instead, this whole concept of the prediction is very reliable method of the volume removal or free water removal. Easy to use it, highly automated setup and operation with only one setting. Believe it or not, when you hook it, you just need to dial. If you're doing the run, personally, we ask the nurse, just increase it to 200. It's a matter of less than a few seconds, honestly, they dial it up. So it's easy to use. It can be accessed, I'm going to get to this part, peripheral and the central. It's going to be a prescriber. You don't need a nephrologist because the principle of the filtration that we're doing it or the dialysis, the two different principles, is a lots of the base of the physiology we have to know. On this method, as a matter of fact, you're just going to remove the free water. And then there's a couple of points, I'm going to mention it shortly. Use as far as the nursing, we hope that we have one of the machine, but you can see it on the booth. We have a patient, when you do it, honestly, they can walk with it in the ICU. Having said that, if they use it on the step down, patient can be movable with it. And the nursing ratio is a 4:1, and patient, as I said, is ambulate during it. So what's the indication? He got the approval, if I remember correctly, 2002 has been in the market, or 2003. Can be used temporary for a patient with a volume overload and have failed diuretic therapy. So you give a diuretics, we don't get a response, and you want to remove the volume. We did it several times. Particularly, let's say, good example of it, the patient has a dissection, massive amount of the transfusion is happened. Sometimes I remove it within, as soon as the patient, they come and the kidney response is not great. Within the first 8 hours after the surgery, we start to remove the volume. And I tell you why this method is going to be helpful. We can use it extended time. Those people who are, a friend of mine just is telling me he's working in the ECMO CT surgery. For those people, let's say on the ECMO massively resuscitated, is as long as the line is there, instead to see and patient stabilize, with the hope is going to be stabilized, and then you remove the volume, we are very aggressive because of that time frame I told you. So we can be extended time, and I use it more than 4 days. The filter time on the machine, the company recommendation is 92 hours. But you remove it constantly the volume to catch the multiple pressors and high maintenance the patient is getting. So how the different society has been used, if you see, the idea was first the American College of Cardiology, American Heart Association, they used the ultrafiltration during between 2002 and then 2008-9 was. Then is a heart failure society, if you see it. So the first two society, they recommended when the diuretic fail. But if you see the heart failure society, ultrafiltration may be considered in lieu of the diuretics. It means you give a diuretics to the patient, but at the same time, you have to remove more volume. So their recommendation is, can you add it together? Particularly in heart failure society, if you see their guideline, when you have a RV failure, right ventricular failure. Then other society, European Society, and then Canadian Cardiovascular Society. So those are the starting recommendation, but the usage, as I said, is two important factors. Not you just need to be Lasix naive, quote unquote, or non-responsive to think about the aquapheresis. So what's the clinical evidence for it? The series of the study has been highlighted, but just getting the last one was the AVOID trial, which the objective was to get it to 800 patients, but they stopped the study at the 200 because the sponsor didn't want it to support the whole study because it's some of the internal issue that the company that they have. But if you see it, What we know in the cardiac surgery, mode of the ultrafiltration reduced duration of the assist ventilation. Post-op cardiac surgery, we know that. We know combined conventional and modify is safe in the adult. I know you wanted to expand it to see if the pediatric people, they're going to use it or not. Ultrafiltration improve cardiac performance because if you have RV dysfunction, by removing the volume, you are going to have a better performance of the right side, and then lots of the case nowadays, complicated case, RV failure can cause LV failure. So by removing the volume, then we have a better RV function and therefore better LV function. And then ultrafiltration after cardiac surgery may reduce the need for the blood transfusion, because nowadays, as those who work in the CT surgery, they know the transfusion is a quality metrics after the index cases. But go back to the study of the AVOID trial. I told you they did around 200 patients. I think if you read the detail of the patient, the whole design of the study was not to see how this aquapheresis helping those patients admitted to the hospital. The idea was to compare it with the diuretics to see how long they are going to be free from any symptom of the heart failure. So the two different principles has been tried in this study. So if you see it, is on the y-axis percentage of the patient free of the heart failure event, and on the bottom one is the time of the heart failure event. If you see I have a significant difference, it means till 90 days, if a patient remove the volume, the symptom of the heart failure within 90 days is around 48 to 53% rest, which is amazing data that came up. So what about the product overview? Product has a console, very small machine that hopefully you can see it in the booth. Then you need the access, we're going to talk about it, and then the blood circuit set. So let's first talk about the console, then is blood set and the access. So it is important to say, because it's removed the isotonic volume, so if you see it, it doesn't need a CVVH when we're running it, and then you check the panel quite often. Honestly, once a day is quite for the electrolyte is enough, which we do it as a routinely, and then it has been shown to have no significant change. And I get to that part why. Reduction of the neurohormonal stimulation is stabilized to improve the cardiac hemodynamic, restore diuretic effectiveness, and 53% reduction of the risk of the rehospitalization for heart failure, which I mentioned to you. So let's see if we can run this animation. So if you see, it has a rotary pump. It's going to, through the venous access, that red line, the blood is going to go all the way to the filter. And then through the filter, through another rotary pump that you have, the ultrafiltrate is going to come out. At any given time, blood volume outside of the body is around 33 milliliters, is important. And if you see on the principle of it, so when the molecule of the water actually get out, some of this electrolyte is going to get out. So it's a dragging force that is going to go. So it's a simple method that is going to be through this venous access and they remove this isotonic volume. Slide is a little bit crowded, but the main point, if you compare it, the CVVH or the continuous renal replacement therapy, which is on the right side compared to the aquapheresis, is that the four major, I think honestly is a few more, but the four major difference. One is the flow rate. If you usually the CVVH, my understanding, most of the people, they use it around 180. That's the magic number. You can come down on the machine to as low as 120. Chance of the thrombosis and the machine alarming is significantly higher. But this machine is going to use it between 20 to 40. So hemodynamic effect of it is significantly less. particularly those of you who does the CVVH, you know that if I, let's say on time 0 to 1, I give 2 antibiotics to the patient with a volume of 400, and I wanted the patient be a net 100 cc negative, it means the next hour I'm going to remove at 550 or 500 to get that achievement. Removing that much of the volume in a period of 1 hour, patient become hypotensive, especially if you want to remove the net negative. This one. The second one is blood volume, as I tell you, is around 35. So if you lose the cartilage, so the CVVH, you get a good amount of the blood, especially those on this patient who are on the TAH, total artificial heart, or ECMO. If you want to prevent on the transfusion, each clotting of the circuit on the CVVH, you're going to lose good amount of the volume. This machine is significantly less. Venous access can be done preferably compared to the CVVH. And then there's, as a prescriber, which is important, you don't need in the middle of the night. If you want to start it, you got right away, you can go ahead. All right, about the venous access, all the Shiley catheter that you have it or use it for the HT catheter, this machine can use it. But the minimum that you need is a 216 lines. So if you have a central, you can get the dual CV, central venous access with 14 gauge. You can have a dual with the 16 gauge. And if you see, the company is actually making this dual lumen extended length catheter, which the length of it is around 15, if I be correct. And then they have a coil and can be inserted peripherally, either brachial, if somebody has a good size brachial, or can be put it on the basilic vein. What is not recommended, definitely cannot use on the PICC line because the resistance is too high. Secondly, if you have an angiocat and the size is, let's say, 18 for sure, is not working. But we have been creative during this process of the CVVH. If you look at the introducer of the Swan Gans or the Cordis that you're giving it, it has a decent sized lumen. We can get it through the venous line and return it back to the size of the 16. So some of those patients acutely, they come out of the operating room and they, let's say, massively hypervolemic. Then we did that and has been successful. Believe it or not, in matter of, I remember a few years back, I had a patient with this young lady with the aortic dissection, came out, was roughly is around 20% of her body was a morbidly obese patient. Over her actual base, the volume was high, did not have a great access. We just started with the AQUAPHERESIS right away as soon as the patient came out of the OR. By 24 hours, we were able to patient keep it around 1.5 liters negative. And the second day, we continue with that. So it means you can be a creative, and we have been it. But that is going to be usage of the size 16, minimum of the 16, and can be preferably inserted. Then it's going to come with the question as far as the anticoagulation. Our patient in CT surgery, exclusively, we don't use the anticoagulation. Why is that? Because we put a bigger Shiley catheter. So the larger the lumen, shorter duration, depends on how much anticoagulation you need. But definitely, if somebody be a post-op, let's say day 7, or somebody on the floor that you want to start it through the peripherally inserted catheter, is advised to put the anticoagulation. Is it need to be a certain number to follow? My experience say no. Because when we do that on the ECMO patient, we are going to see a different ACT and as how our catheter is working. Honestly, personally, I can tell you last 10 years, if I had a CHF solution, if it be clogged off, most of the time something wrong with the line. Either it's kinking or you have a clot in the line is performed. Machine by itself rarely needs anticoagulation, but I'm talking immediately post-open heart. But if you get the long term as a peripheral insert, definitely need for the lifespan of this extended lifespan of the filter, you need a anticoagulation. Then is a new feature of this one is coming out. The method is you can put it on the, it's like a pulse oximetry and can estimate the crit. So the idea is when we remove the free water, let's say if I started with the crit of the 25 and you remove the volume, assumption is the crit is going to go up. So what this machine can adjust this crit level that you're desirable, that you want it, and automatically let the ultrafiltration to a stop, but the pump is working. So those are the good if you want to have an extra safety feature, if the patient has it in the most of the time on the step down, because in our ICU we have 24/7 intensivists. But if you want an extra step or certain level of the volume removal, is a parameter is going to help. And as you said, is the automatically turn off the ultrafiltration, and value are graphed and visible on the console. So another one important concept that you have it, ultrafiltrate is amount of the isotonic fluid is going to come from the intravascular. So when this machine constantly remove this one, cause the fluid from the interstitium move it, which we call it plasma refill rate. The fluid is going to go. So if you want to remove it, the idea should be to get to the steady state, the rate should be about the same. So if you see on the graph on the right side, so on the beginning, this plasma refill rate is going to be high, but the more ultrafiltration, let's say after 8 hours or after 24 hours in certain patient, then the rate can come, is going to be the rate of the plasma refill is going to be reduced. But that is a judgment call. Different people, they're doing it differently. What usually you wanted to do it is started with the lower rate of ultrafiltrate, like a 50 to 100, and then increase. This machine can go as high as 400 per hour, 500, sorry about that. So personally, I use a 400 for a few hours massively, and then we came down. But as you said, 400 of 10 hours is equal to 4 liters of the free water removal. If somebody get the maintenance of the, let's say, 180 cc because of 3 or 4 pressors, at the end of the day, not only you remove, the patient is not more volume responsive, you're removing roughly around 2 liters volume on this patient, which is a significant achievement. Yes? I'm sorry? What is the whole concept is that, so let's say you have to estimate it. So when you dial it on the machine, let's say you want 100 cc of the fluid removal. So you want to estimate what is the total body water that you have. If you dial it, let's say 350, sometimes we do it, and then 24 hours you're removing 6 liters. But the assumption, generally speaking, we don't want it to total water net on the patient according to their weight, something between 2.5 to 3.5 liter volume removal. So it means if you get some people, they get excited, so they dial this machine up and their expectation is they're gonna 6 liter of the volume they remove. What happened, patient become hypovolemic because the refill does not happen. So what we want at the end of the 24 hours on the acute setting of the patient, we want a roughly between 2.5 net volume removal. So what we're achieving it, those who get, let's say 200 cc per hour, I might do it 400 net removal by the ultrafiltration, which at the end of the 24 hours, roughly I'm ranging between 2.5 to 3.5. It's gonna come a little bit with the experience, but the volume removal, this concept should be back of your mind. You remove intravascular, the idea is the interstitium is gonna put the volume back. Another point to get to your point is a different formula. Actually, during the 60s, they come with the total body water and the intravascular volume through the hematocrit. Sensitivity of it is around 70%. But if you look at it, everybody agrees 12% more than a actual body weight. If you get the volume, you're gonna be a hypervolemia. And then usually the correction should happen is about 8%. But those are, as I said, with the experience that is gonna come to your, Summary, simplified form of ultrafiltration can be prescribed by any physician trained in extracorporeal, easy setup and monitoring, allowing 4:1, approximately 35 milliliter of the extracorporeal, and no significant change to electrolyte balance. I'm happy to answer any question. Yes. Oh, the question is, does this machine affect any certain medication? The answer is no. Pardon me? The antibiotics and no. The only thing, if you wanted to do it, just remember, if the patient, let's say you give a vancomycin, when you're on this renal replacement therapy, you are going to change the dosage. This machine does not give you the clearance. What it does is just remove the volume. So dosage has to be adjusted as a renal failure patient. Hypernatremia, hypo. You can calculate the total dioxide, body water, and how much. This is actually, if you have it, quite interesting. We have a few cases that the patient come back to us, we get it, and you have 100% control to don't over-treat it. Because let's say with sodium of 123, expectation is going to be what at the end of the 12 hours. Precisely, we can achieve it, and we have done it. It's a very important point for hyponatremic patient. No absolute contraindication. This is a filter, the heparin. The heparin, as I said, most of it, honestly, I don't use it. Let's say if I have a post-op day 5, I might put a little bit like a 500 unit through the circuit. Having said that, if you have a longer time and the patient has a peripheral access, definitely recommended to bring a little bit of the heparin higher, at least 1.5 times of what needs to be done. Because the design of some of the study was, they were so involved, particularly between 2002 to 2009, peripheral access and then heparinization, how they are going to, reliability of the PTT as you see it. So what you needed in acute setting, rarely you needed, but you needed for the long term, you needed some anticoagulation. I personally, we use it quite often. With the two, I think is essential. As you know, hypervolemia, hopefully I initiate this thought that we are very, as an entity, is a parameter we want to take care of it. Certain group of the patient, heart failure, RV dysfunction, that's one. And the second thing, we don't want it to wait. So as I'm pretty sure you know it, the creatinine, when you say it, the creatinine and the clearance creatinine, when you have an AKI, is not the linear. So it's the concept is, unfortunately, lots of the people, they have it. And then the lab nowadays, by the state requirement, they report to the, if you have a, let's say, creatinine of 1.6, they estimate your GFR. But somebody with the AKI can have a creatinine of 1.6, the GFR might be 5 cc. So if you look at the urine output, I know a friend of mine actually is in Connecticut, they don't report the estimated GFR. So we are very avid appreciation of this idea of creatinine in acute setting. Doesn't tell us what the GFR would be. And then if you have a hypervolemia, we are going to address it fast because it has an outcome effect. Any question? All right. Thank you so much. Thank you.